My name is Diana Romero. I am one of the Learning and Development Coordinators here at the Refugee, Migrant, and Technical Assistance Center for Behavioral Health. We're also known as RMTAC, and I'm excited to welcome you all to the first session of this learning community. Our learning community is a multi-session learning community, meaning that each session builds progressively on one another. So today we are going to be focused on behavioral health and psychopharmacology for refugees and migrants, specifically focused on behavioral health disorders, symptomology, and barriers to accessing psychopharmacological care. We hope that through this learning community, we can foster a collaborative environment where we can share knowledge, resources, and best practices. Like I mentioned earlier, what differentiates a learning community from a webinar is that active collaboration, both from you and your peers, as well as our subject matter experts. Through these collective experiences and expertise, we hope that we can all enhance our capacity and service delivery, ultimately making a significant impact on the lives of the communities that we all serve. And I encourage you to actively participate, share your insights, ask questions, support one another through this process. And remember, the strength of our learning community lies in your willingness to collaborate with your peers and those that are here today. So thank you so much for being here. As you can see from our agenda, we have a pretty full day packed. We'll begin with introductions and learning outcomes. We'll hear from our subject matter expert on common behavioral health trends. We'll have a collaborative breakout session that discusses culture and symptomology. Following the break, our subject matter expert will address barriers to accessing psychopharmacological care before we close out the session. So pretty full agenda, and we're hoping to keep it fun and engaging the whole way through. I am excited to introduce our esteemed subject matter experts who you'll hear from later in the session. First, we have Dr. Hector Colon Rivera, who is a quadruple board certified psychiatrist and medical director of APM. And Candace Radetsky is a psychiatric nurse practitioner here at RMTAC. We're grateful for their presence and commitment to the communities we serve, and I personally am really looking forward to hearing from them later today in the session. I would also like to introduce our subject matter experts and facilitators who you'll hear from during our breakout sessions later in the session. They are our clinical case consultants on our RMTAC team, so thank you to Dr. Mutsa Majero and Dr. Muhammad Ali for sharing your expertise with our group. Once we break out into breakout sessions, you will have one of these facilitators in your group. All right, and we also have a solid group of producers working behind the scenes to make everything run smoothly. If you encounter any technical difficulties through the session, please feel free to reach out to any of those people. Their roles and their names will be in the window, the video window, and you can ask them any questions that come up. They'll be there to answer and help with any of that. So thank you so much to our producers. They make everything run smoothly on the back end, and I'm super grateful for all of them. So today during our learning community, we will have a lot in store. And now that we've gotten to know each other a little bit better, we'll jump into our session. But don't worry, we're still going to have lots of fun in store. So in today's session, we'll collaborate with fellow health professionals to share experiences, strategies, and solutions for addressing common behavioral health concerns. We'll recognize behavioral health trends and effective strategies to support the unique needs of refugee and migrant clients, and analyze how cultural factors influence symptomology, and lastly, examine barriers to accessing psychopharmacological care. Say that 3 times fast. As mentioned earlier, this learning community is meant to be highly interactive and engaging, so we really look forward to all of your insights as well. So you might be wondering, why psychopharmacology for refugees and migrants? Well, for many reasons. One of those is CTA requests. For us, we do consultation and technical service requests. And those requests that we've received have been asking for a lot of feedback on this topic, specifically in guidance for navigating psychopharmacology interventions within diverse refugee and migrant communities. Many of the providers that are looking for assistance with this are looking for strategies in recognizing the need for intervention and overcoming some of those barriers to care, which we'll dive into later in the session. In addition, we did an extensive literature review with over 3,000 articles. 143 of those articles emphasize the unique mental health challenges faced by marginalized groups and the importance of appropriate medication management to address those specific concerns. So as you are probably familiar with, we have a very diverse group within all of our communities. And a lot of times that does come with some behavioral health and mental health disorders. And oftentimes those people are a little bit hesitant to access psychopharmacological care. So that is one of the other reasons is we want to figure out how we can help them in that way. And the pre-reading materials that were sent by email, you received one of those articles. What mental illness means in different cultures, perceptions of mental health among refugees of various countries of origin by Moses and Holmes. They highlight the importance of this topic as well, as the authors found significantly more post-traumatic stress disorder and depression in refugees and asylum seekers than in the general population. So that really shows that there's a major need for this. In addition, the study revealed that one of the primary barriers to seeking help relates to the perceptions of mental health and mental health treatment, which I'm sure many of us are familiar with. So overcoming those barriers to mental health care is even more challenging because of the immense diversity across those populations of refugees and migrants, host countries and context. So mental health perceptions differ between cultures, and diverse explanation and belief systems impact that as well. And the article identified that perceptions of mental health care according to their country of origin change, right? So knowing these cultural differences has the potential to improve mental health care and open the door to treatment. So in our breakout sessions later, we'll explore some of this presentation and what it looks like in various cultures. So you might have received that article in the email we sent in the pre-reading, and hopefully you had a chance to browse over that. Lastly, during our needs assessment, many providers indicated a high interest in training for this topic and assistance to topics related to managing behavioral health concerns within this population. And the need for destigmatization of psychopharmacology intervention. So how do we destigmatize that a little bit within those populations as well? So as you can see, the topic is highly requested, and we hope you find value in it, just as we are finding value in it since we've been sharing this with other providers. At this point, I will turn it over to Dr. Hector Colon Rivera. As I mentioned earlier, he is a quadruple board certified psychiatrist and medical director of APM, a nonprofit dedicated to enhancing the quality of life for Hispanic communities in the Philadelphia region through direct behavioral health and substance use disorder services. APM also provides critical support for refugees and underserved groups through its comprehensive education, health, human services, community support, foster care, and economic development programs. In addition, Dr. Colon is also the co-founder and chief medical officer at OK Health. He is an attending physician at Western Psychiatric Institute and Clinic and UPMC, a clinical advisor for the Advisory on Alcohol and Other Drugs Committee for Pennsylvania. He is also an active member of the Hispanic Caucus of American Psychiatric Association Assembly. Welcome and thank you for being here, Dr. Hector Colon.
Thank you for the invitation. How you guys doing? I see that you're coming from different parts of the country, especially Arizona. I mean, that's great. Never been there, but it's on my bucket list. There you go. So to start the conversation, I want to differentiate between what's a refugee versus a migrant, and this is important to know. I'm pretty sure most of you guys know, but a refugee is someone that didn't choose to come here, right? Didn't choose to move. It was felt obligated or there was because of safety issues, either war or trauma or something going on in their countries that they needed to move. A migrant decided to move. They chose to move to outside the U.S. Our country. I mean, yeah, in the US outside the countries. So a few examples of refugee origin. This is from 2022. The Congo, Syria, Ukraine, Afghanistan, which Arizona, and talking about Arizona, a lot of people in Arizona, refugees in Arizona are from Afghanistan and the Democratic Republic of Congo. So I wonder if you guys see some of these refugees. And on the other side, we have top migrants origins, which is Mexico, India, China, the Philippines, and El Salvador. I do work a lot with people from Cuba, Dominican Republic, and Mexico in my community. Also, people from Somalia, when I work with some of the clinics in Minnesota, for example, we have a lot of Somalian refugees in Minnesota. And this is just to show you that every month, every year, every week, things change around us. That's what's really important to have conversations like this and technical assistance because it can change. Next month, we'll have a different a group of migrants from different part of other country moving to the US or refugees. And this is just an example. We know Mexico kind of stay on top. Numbers don't change per month by month. But we see countries like, for example, Ecuador, we see a big change month after month. We see how places like in Nicaragua, depending on what's going on in the country, we saw a surge from August to September in Nicaragua, and then it stayed about the same. So this is just to show you how fluid the refugee and migrant situation can be, and how we need to prepare for these changes and things that we need to treat. Some key factors. Globally, migrants are estimated to be almost 300 million international migrants. This is back in 2018. This is it changed fast. I mean, we're seeing more and more. Some years it decreased depending on the patrol and the resources the government is putting in. Example, we'll use Arizona again. I mean, we have seen a decrease in the last year in 2024. A decrease of 20% of refugees because they increased the patrol in this area. It's still a pretty good zone, and they're advocate for refugees and asylum people in Tucson, Arizona. That have not changed. It's a sanctuary place. So it's really important to stress that. There's some migrants and refugees often face a lot of stressors that impact mental health before and during and after migration, right? The stressors do not stay home. They bring their stressors with them when they move here and they stay here, of course. That's why it's really important to know about this. There's a higher prevalence of common mental disorders, especially depression, anxiety, and post-traumatic stress disorder are the most frequent ones that we see in this among these populations. There's a lot of access barriers to care. There's stigma. There is a lot of challenges in the communities. I mean, we can talk about social determinants of health all day long, but transportation, education, language is a big one. And all this situation put a lot of mental health services barriers for them. Inclusive approaches, we have to have that. We need to include promotion, prevention programs. We don't do a lot of prevention in the US. We're always trying to be treating, no prevention, or implementing ways of prevent disorders from happening when the symptoms are first happening. So we need to improve that and connect general health services with mental health services. There is a lot of positive contribution from migrants and refugees to benefit society. And of course, we need to help to keep those contributions happening. So this is the QR we talked about at the beginning. Please scan it with your phone and answer this question with a word or I guess a sentence, probably a word, and we'll see that on the screen. Yeah, we see on the screen how fear and anxiety, right, are the most common that you guys are seeing. And of course, in the background, trauma, anger, post-traumatic stress disorder, uh, right? So there's pretty, it sounds like anxiety is winning, right? Anxiety, we see a lot of anxiety, and that's the most common behavioral trend that we see in our clinics. I agree with that. So some research on behavioral health trends in migrants and refugees. in the community. So we see a high prevalence of trauma-related disorders, PTSD, post-traumatic stress disorder, up to 40%. That means that 1 out of 3 suffer from traumatic stress disorder symptom or diagnosis. And of course, I mean, this is a lot higher than general population when we see a 7 to 10%, depending female, male, for the type of trauma. But in this population, we see about 40%, which is a huge change. We're talking about 3 times the general population. There's a acculturation stress, which we see. I mean, is hard to get used to the forms, the language, the way of doing things, the employment, social isolation. I see a lot of patients that are coming for as refugees or migrants that they have their own career at their place. Where they are, well, before they were lawyers, doctors, teachers, educators, and then they come here and need to adapt to that, the change, a big change, and maybe look for a different job, and of course a different lifestyle and style of living. We suffer a lot of underdiagnosed, sometimes over-diagnosed, that we present with depression, and we are diagnosed with psychotic features of things like that because of the way we act, the way we look, the way we move and talk. I mean, is misdiagnosed. So a lot of stigma and limited specialists available in the areas that they usually move. I mean, remember the city is more expensive. It's hard to get to the cities, so we tend to go to rural areas where there's less specialties. Most common mental health disorders needing psychopharmacological intervention, so post-traumatic stress disorder, mood disorders, anxiety disorder, and of course, co-occurring disorder that can be part of a combo, right? That comes with, it could be with psychotic features, could be due to substance use, and of course, there's a lot of chronic medical issues that present with some mental health symptoms, like thyroid disorders, seizure disorder, epilepsy. They could present with a lot of mental health diagnosis or confounding factors. So in PTSD, I think a combination of trauma-focused therapy is really important with medication has been found, to be more helpful, having both. But some people decide to go one or the other, especially if there's a lot of stigma in terms of using medication in some countries. Mood disorders, we'll talk about more about medication later in the presentation, but just an example, SSRIs are kind of the first line, also SNRIs, and we need to monitor side effects and adherence. Same with anxiety disorders, and of course, co-occurring disorders. We usually recommend to treat both disorders, the 3 disorders, we're talking about 3, at the same time, and not just wait for one to get better than before the other. Mental health disorders in refugees and migrants, this is just a follow-up. Again, I keep repeating the trauma situation because that's kind of the most common disorder that they come with, even if they were not diagnosed before they came here in the US, because there were limited resources, or they come with diagnosis and they call it a different way or different symptoms, right? Remember that we use the DSM-5 only in the US. Some countries use it as a reference, but every country has their own criteria for in terms of diagnosis. Anxiety and depression are pretty common as well. They worry about their families, the life they left behind. They worry about the future, the present. Why are we here? Especially refugees don't have that option, and migrants, of course, they're looking for something better. Most of the reasons to move to the US is because they're looking for something better. Some obsessive compulsive disorder, not as common, but present. And these are intrusive thoughts that they cannot stop. I mean, they kind of stuck in these thoughts unless they do a compulsion, which is the action to resolve the obsessions. And substance disorder, yes, we see a lot of, especially alcohol use on migrants, a lot of tobacco use, and that should be treated at the same time as medical disorder. And we know the medical disorder usually present before the substance disorder. In most cases, probably 70% of people present with a mental disorder before they have a substance disorder. The substance disorder is just a way of medicating or self-medicating the mental health disorder. But it's really important to treat both at the same time. Mental health disorders in refugee migrant also includes grief. I mean, some of them feel shame or guilt about leaving their families behind. They don't have the home that they want to. They're not familiar with area, so it's a alienation because of that. Chronic stress, ongoing stress from uncertainty or the uncertainty of legal status that they cannot control. Right, depends on other people, depends on the state, depends on the federal government, depends on other people like lawyers and things like that. So they do not control a situation. It's really hard to understand that when you were in a place that you used to control things, and then you come to a place that you don't understand language, and then you don't control anything, and the laws are different. Uh, and there's a lot of somatic symptoms. And I mean, I'm a Hispanic, so I know my own symptoms, right? And somatic symptoms. But a lot of other countries suffer from that too in different way. There's a lot of countries like Haitians, that I see Haitian, they have a lot of spirituality symptom with spirits and things like that, and they perceive voices of or feelings that are different than Hispanics in terms of somatic symptoms, but they're there, right? In terms of Hispanic, we see a lot of headaches, feeling tired, and things like that. And kids present in a different way. I'm a board certified psychiatrist that see a lot of adolescents, especially adolescents, 10 and up. And kids usually present with more isolation and irritability comparing to adults. But of course, they suffer educational challenges. Sometimes uh, they need to repeat the grade because of language issues and other situations that affect their and present as physical symptoms and like headaches, feeling sick, and they don't want to go to school. Intervention and prevention is really important. Early symptom recognition with scales. We have the refugee health scale, which is a good one, includes a lot of this, what we have talked, especially somatic symptoms that can be identified and underline some of the anxiety and depression. PHQ-9, which is the most common scale out there. I mean, there is the PHQ-2, which are two questions in terms of feeling depressed or feeling suicidal, and then the PHQ-9 is a little bit more of the same, but adding like concentration issues, appetite, and energy, and other things, and also suicidal ideations and thoughts. Um, but the importance of this is that like usually RHS-15 includes a lot more, including somatic complaints. And this can help primary care physicians to identify some of the symptoms so they can treat or refer to a specialist in behavioral health. Psychoeducation really important. That's what we're doing today. We're talking a lot about psychoeducation and prevention today. So knowing what's around your community, knowing who has been trained right on these populations is really important to know. So making a list of those resources for you guys is really important. Training all staff and recognize behavioral health concerns. I mean, comprehensive staff training, and this includes all staff. We're not talking about just prescribers or providers or counselors. We're talking about people from like the cleaning department, the front desk, the security guy outside. It's really important for them to know, the care that this patient might need. Some of our patients are pretty sensitive, or they are in sensitive, vulnerable situations. So we need to be empathetic. We need to be a collaborative environment, and it has to be clear. We need to have a guideline and pathway to do this. Cultural competence or cultural humbleness. I mean, people call it from different ways. So an example is use professional interpreters. Don't use family members. Don't use staff or your clinic. Use interpretation from a professional. And of course, resources are different in different places, but if it's available, use it. And we need to recognize historical, socio-political context affecting the presentation of the patient. So knowing, that's why I present where the patients are coming from, to know a little bit. I mean, it's good to know the context of the country of origin. So it's something that we need to learn about. And how culture influence symptom presentation. We talk a lot about somatic because that's really, we need to learn that somatic symptoms, and they present in an emotional way. Also the emotional display they present. So cultural norms are different depending on the country you're coming from, and some groups tend to minimize or internalize emotional suffering. I see a lot of Asians, for example, culture, they tend to do that. I used to do a lot of Vietnamese mental health, and they tend, especially males, to hide some of the emotions. We see that in Hispanics too because of machismo and other situations. So that's really important to then be identified. Spiritual and traditional belief, depends where you grew up and the family you have. So it could be related to spirits. Of course, I mentioned that the Haitian community believe a lot on this, but also Jamaicans and other part of the Caribbean, like Dominican Republic and even Puerto Ricans, do have some spiritual belief. Not saying that Puerto Ricans are refugees or migrants, but it is a different culture. Um, Practical tips for implementation. So routine screening, I gave you two of them, but there are multiple of them. So and you guys have questions about other screening scales. Of course, you can contact us. But two basic ones, the RH15 and PHQ-9s are really basic ones that we can use just to know what's going on and it will help us to I guess create a treatment plan for that patient. Multidisciplinary team, depending on resources, but it's really important to include other people, have communication with primary care physicians, social workers, lawyers, anyone that's around your community that can help with services. Cultural consultation is really important in both cultural license and health navigators, case managers, depending on the resources, but they are mostly available. Clear referral pathway. I like when the primary care physician call me directly and present the patient to me. Also, when other staff members they do the same, right? So having that warm off presentation and referral, it really helps. Follow up and continuity, that's the key. We want the patients to come back. Also include the family if possible, include the schools if possible, and just track treatment response and metrics, right? Follow up the PHQ-9s, follow up the GAD-7s. All these scales can be follow up and metrics. So you have a good performance metric for that client in particular. Thank you.
Thank you so much for sharing your expertise, Dr. Hector Colon Rivera. That you gave us a lot of great insights on how we can navigate some of that culture and symptomology. And we will discuss that next in our breakout room. So we'll have an opportunity to dive a little bit deeper. And for some of you, Dr. Hector Colon Rivera will be in your breakout room to answer questions and guide you through that conversation, as well as our other subject matter experts. So in a few moments, we will begin the transition to our small group breakout sessions as we discuss culture and symptomology and how it presents for the communities that we're serving. It is important to note that all cultures are different and individuals within a culture are different as well. And as our pre-reading materials indicate, that can be very diverse and there's a lot to think about there. But as we combine all our shared experiences, we can be better equipped to support those communities. So as we transition into our breakout room shortly, you'll get an opportunity to have those discussions with your peers. In this activity, you're going to break out into small groups. Each of those groups will have a subject matter expert / facilitator and a producer. Your group discussion will be guided by your subject matter expert / facilitator. And the producer assigned to each group will be taking notes on the screen. Hope you all had a wonderful breakout session. From what I heard, it was very robust and interactive. So thank you so much for your participation in that. Okay, so we are going to kind of recap what we talked about in our breakout rooms. So at this time, we'll take a few minutes to hear from each group. I know that many of you have chosen a spokesperson. When you're ready, we can share, or I can call on group 1 first if you're ready, or if anybody would like to volunteer.
I can go from group 3. No one wanted to volunteer, so I'll kind of sum up. what we chatted about. Some really cool, interesting trends that have been noticed within the refugee migrant community, one of which is that alcoholism seems to be increasing, but across, like, with no specific culture in mind, so just like across the board, which is really interesting. As well as just kind of what we're, you know, rolling into for next is the access to care, language lines, you know, proper diagnoses, you know, really making sure that providers are doing the most they can for the clients, as well as general signs and symptoms, which look very different across different cultures, especially because our the two primary people that were in our group come from very populations who have just integrated into the United States, so it's very fresh. So talking about a honeymoon period where they feel like things are good for so long and then symptoms really emerge, and that looking different cross-culturally. That's kind of our focus was.
Thank you so much for sharing. I think that's a really great insight, just that there is a little bit of that time when it's like filled with excitement, right? I can share from my personal experience of my family immigrating to the United States. There is that time of like, wow, this is opportunity. We have so much opportunity. And there's this excitement of getting to make something and build something. And then oftentimes that's followed with the realities of, you know, how difficult that can be for a lot of people for coming in from other countries. So that's a wonderful insight. Thank you all for sharing. Anybody else like to share?
I think we were group 2. Is that right, Sophia?
Yes.
Okay, so we kind of went over GAD, major depression, a little bit of PTSD, and substance use. So we talked about, we also kind of hit on substance abuse and how we've noticed alcohol use. Some thoughts that were brought up were kind of cultural, maybe subcultural influences, that maybe expose and normalize substance use, as well as maybe having substance use, specifically alcohol, be seen as like maybe a badge of honor, potentially having that heavy drinking be a masking. And then we did we touched about stigma, how maybe back older generations, or it was not talked about, was not normalized to discuss any kind of mental health issues or anxiety. And nowadays we're seeing a lot of the younger population are feeling more comfortable and opening up and sharing about any mental health issues that may be coming up. If I missed something, feel free to chime in from my people, but that's pretty much what I got.
Thank you. That was really insightful. I think I'm curious, when you spoke in your groups, was there a specific culture you identified with the like focus on alcohol, kind of like as a badge of honor, or was it kind of just overall?
If it's okay, I want to pass it to Gabriel. He was in my team and he was the one that kind of mentioned some insightful comments about it.
Sorry, I was just explaining the experience based on the children we had before in the program. And I was explaining to our other persons there that most of the times when the child comes from Venezuela, Colombia, Honduras, they have this exposure to cultural like reggaeton, like Daddy Yankee, I mean Nicky Jam, Bad Bunny, this kind of person that they influence on their video about people drinking and smoking. Also Mexican bands, they have some videos that they're drinking, smoking, degrading the image of a woman, like almost half naked or showing their bodies. And when they ask me, what do you think about the youth from Guatemala? I say, usually they're poor, they live in a rural area where it's away from that influence, so they don't have that kind of influence on them. And also when you go to enjoy a time with a party with your friends, there's always someone that is drinking, and then whenever it's alcohol, you see a cigarette. Whenever it's cigarette, you see marijuana. When you see marijuana, you see heroin or coke. So usually everybody has one kind of drug to share with everybody on those kind of parties. That's what I was explaining to my coworkers.
That's interesting. And I feel like that can kind of translate to a lot of cultures, right? I'm specifically from Serbia and we have like a very Russian type of influence in our culture. So like there is somewhat of a praise culturally of substance abuse being like, emphasized, specifically alcohol. So I can see that happening in other cultures as well. Thank you so much for sharing.
Also, Amira was also there. She was explaining that she come from Sudan and do the war and many bad situations happening over there. People, refugees on alcohol and other kinds of substance just to deal with the pain and the situations and the trauma. So also happens on in that side of the country.
Yeah, collectively, right, as a culture, even where I'm from, you can see that in a lot of the communities because they've been subject to so much community trauma. So it just kind of perpetuates that need for self-medication. Thank you. Anybody else want to share before we move on?
I can share briefly from our group. So we just kind of highlighted a lot of how we've seen the various mental health concerns be presented. So we talked quite a lot of, as well, sleep disturbances came up a bit in each of like the different categories. Also talked about somatic symptoms. I shared a little bit about being from Zimbabwe, how a lot of times in my culture, how I've seen it, people aren't going to come right out and say, I'm sad or I'm depressed or I'm anxious. It's just going to be a lot of somatic symptoms. My stomach hurts, I've got a headache, I just don't feel well. And I also shared a bit about how, a lot of times with refugees or migrants, there's a lot of family expectations, even if they've moved here under not so great circumstances. The fact that they're here and family back home are looking at them like, but you're the one that got away, you're good, you're in America, you shouldn't be sad or anxious or struggling. So people really have a hard time expressing when they experience any of these mental health concerns because of that pressure to keep on a brave face and just push through and help take care of the family that's back home that couldn't make it out. So that's some of what kind of came up in our group discussion.
Wonderful insight. Yes, I could see that happening. Something that automatically comes to mind is in my culture, we don't have a lot of those emotive words, right, to describe anxiety, depression. Just even the language to verbalize that isn't present in our vocabulary. So how do you identify that it is going to come a lot with those somatic symptoms? Yeah. Thank you all so much for sharing. Wonderful insights, and I hope that I learned a lot just from hearing from your discussions, and I hope you learned a lot from each other as well.
Also, I want to mention something about my culture to add it more. Like mental health is a stigma, they look at it as a stigma. So, for example, if you have a depression, instead of getting like a treatment, it'll be like, oh, he just had like being like sad or so they hide it, and the result of that could be turning to psychotic symptoms. So instead of the person get a treatment because of the culture, look at the mental health disorder generally the shame or so it always like sad, like because we're getting more and more symptoms. So it could be like psychotic symptoms, and instead of being treated like in a short time, it could be like chronic illness. So I just want to add that, and this is like typically in my culture.
Yeah, that's a good example. It's almost like the shame and like the repressing of the symptoms compounds, and it gets exponentially more difficult to deal with later on. I think Dr. Hector Colon Rivera wanted to add something very quickly before we transition.
Yeah, just to add to what has been said, we talk a little bit about the consequences not only affecting the patient itself, also family, community, and society. They're seeing a lot of these cases when patients start drinking or using drugs or feeling depressed. They also affect their partner and their family. So that's really important just to talk about. Also, the stages of change, right? How denial and pre-contemplation, contemplation can affect the way you interact with the client and patient. And we mentioned a little bit of motivational interviewing. We were talking a few weeks about that, but we just talk about how important is that part of treatment, right? Breaking those barriers in terms of denial and pre-contemplation on the treatment they're looking for.
Thank you so much for that. Thank you, everybody, for your wonderful insights. In the interest of time, we will be foregoing the break. However, if you need to step away for a minute, feel free to mute yourself and go off screen as we transition to our next subject matter expert, Candace. A board-certified mental health nurse practitioner and a proud graduate of University of Texas Science Center at Houston. She's specialized in 7 years of clinical experience in providing comprehensive medical and biopsychosocial assessments to guide patients through their care journey. So you really take a lot of that medical, biological, psychological, and social aspects into consideration with a patient's history to recommend treatment options. And she has a number of different treatment options, including dual sympathetic reset, ketamine infusions, transcranial magnetic stimulation therapy, integration therapy, and medication management. So welcome, Candace. Thank you so much for being here with us today.
Thanks, y'all. All right. Thank you for the introduction. We're kind of going over mental health challenges in the refugee and immigrant populations, the prevalence of mental health disorders, which was kind of touched upon before. But one of the biggest things here is that refugees are 10 times more likely to develop post-traumatic stress disorder compared to the general population. With that includes depression, anxiety, and coexisting diagnoses that we'll see, which can include substance use disorder as well. Barriers to detection. As we spoke before, a lot of places where we're seeing a big portion of this population are rural areas that already have a lack of services to begin with. So only about 5 to 15% of refugees with mental health conditions have access to care compared to the general population at 45 to 55%. I would say those insured within the United States even find it hard to find a psychiatrist, psychiatric nurse practitioner, even therapy. So imagining lack of resources in rural areas and that barrier to care. What's really important to this is early intervention is probably one of the most important things. As we just spoke upon, is if we don't catch it early, the likelihood of something worsening is much higher. It develops into substance use. It develops into major depression with psychosis. Now we're impulsive, we have self-interest behaviors and, even suicidal attempts. So what's important is if we can get our population in front of providers that can help give those who need psychopharmacological care, that would be ideal. And this is where the need for support comes in. About 20 to 30% of refugee patients require psychopharmacological treatment for the more severe conditions. And most importantly, in our mental health field, is medications isn't the end all be all. It's the culmination of medical support, therapy support, as well as the medication portion. Barriers. So we've got urban areas already have the limited availability just because of the high demand and dense populations we have to even get in. And then you have the rural areas where there's about 25 to 50% less access than those urban areas. And the important part with that is where here at RMTAC is that we are hoping to integrate more of a collaborative care model to give our primary care providers access to myself, to our other providers to have support in those therapeutics as well as medication options. And that's where the medical education comes in. Lack of awareness about mental health among refugees and our migrant populations. It's about 40 to 50% of refugees are unfamiliar with Western mental health care approaches. And I think it's very, very important that it's a combination of both their traditional practices with the Western medicine to make them feel more comfortable. So it's really important for us to have training across the board as well. And then, of course, medications are misunderstood within the population. So it's important to educate. Trust and familiarity. That was a big portion of our breakout, actually, is just trusting the system. There can be a lot of hands in the pot, so to speak, is what I learned. So making sure that there is a person that they can trust and a face they see regularly, which could be that primary care provider or somebody where they can then help guide, understand, and build that trust within one another, and can also break down that cultural stigma, right? We might feel shame or guilt or not understand to be able to put a word to what I'm feeling. So really listening, making sure there's no language barriers, meaning that we need to be using interpreters in our practices and such to make sure that we are helping break down that stigma in a way that everybody can understand, no matter where you're from. And then with the language and conceptual differences, like I said, is I used to work for Indian Health Services for Navajo Nation. So one of the biggest things I learned from coming from big medicine, Austin, Texas to rural Winslow, Arizona, was that integrating our Western medical terms, which may not exist, or understanding what I would be talking about on symptomology. So it's really important to be able to have access to as many resources to be able to break down concepts and allow for the client to understand what we as providers are talking about, so they feel comfortable with the treatment they're getting. And then of course, this is something we talked about, it's really important, is the stigma and just all the change that occurs when you know, coming to the States can cause a lot of adjustment, right? So we call it in the psychiatric realm adjustment disorders. So not only are you going to see that at first, but then probably in the future, more of the other symptoms come out. But something I like to say is, when I'm addressing people who are uncomfortable about the stigma of mental health, is if you had a broken arm, you wouldn't hide it because you were in pain. You would go see an orthopedic specialist. If you had a heart problem, you wouldn't just say, I'm not going to go see anybody because it's part of my body. The brain is still part of the body. And I think it's really important that we treat it as such, just like a broken arm or having a heart attack. And I like to break it down in those medical terms because some feel a little bit more comfortable, or just the brain doctor, so to speak, the thought doc, versus you know, your orthopedic or cardiologist. And that is it. Thank you.
Thank you so much, Candace, and thank you to Dr. Hector Colon, our subject matter experts. Your guidance and insights during this learning community are greatly appreciated, and I personally learned so much tangible knowledge from your expertise, and I'm sure everyone attending has as well. A real quick moment, just wanted to remind everyone that Candace is on staff here at RMTAC, and she is a psychopharmacologist. And so when you submit a CTA request, which I'll go over in just a moment, you have direct access to her. And I know a lot of the issues that we're seeing in our communities is lack of access as well, like we talked about in urban and rural areas. So in rural areas, just not having that, but then in urban areas, everybody trying to get into the same provider. So we have clinicians on staff as well as Candace on staff that are here to help you. And that is a resource that I would take advantage of if you are having trouble accessing that within the communities you serve. Okay, so we've done a lot today. We discussed a lot, we accomplished a lot, we had a lot of great insights. We identified the most common behavioral health trends. Some of those include PTSD, mood disorders, anxiety disorders, and co-occurring disorders. In addition, we analyzed some of the barriers to psychopharmacology, such as resource scarcity, medical education, trust and familiarity, the cultural stigmas, the language and conceptual differences, and acculturation and identity. A lot of you shared a lot of wonderful personal experiences that help solidify some of those terms that we talked about today and give us great stories and insight to what that looks like directly with the communities we serve, as well as the communities we represent. In the next session of this learning community, we will scaffold and build upon these insights from today as we identify solutions to overcome some of those barriers and focus on motivational interviewing as the tool. Next, we learn about how cultural factors influence some of our communities and presented it within symptomology. You shared those specific examples of how those symptoms presented in your community, and like the ones you serve and the one you belong in. And lastly, we engaged in collaborative discussion with fellow health professionals and leveraged our collective experience to tackle this complex issue. And that is our goal with these learning communities, is to continue to lean on one another as a resource. As mentioned earlier, the learning community is progressive, and the next session will be a continuation of the work that we've done today. So the next session will be September 26th at 12:30 Central Time, same time as today. We will send pre-reading materials ahead of time to the email that you used to register, and everyone that attends both sessions will be entered in a raffle for a gift card. So that's a nice little incentive to come back and hang out with us again. As part of the Solutions for Psychopharmacology, we'll share some strategies. Of those will be motivational interviewing. So at this time, I want to quickly just bring your attention to our CTA requests, which I mentioned earlier. If you and your organization need additional assistance with addressing some of these behavioral health concerns, such as psychopharmacology or any topics related to serving refugee and migrant communities, our team here at RMTAC is here to help you. You can submit a consultation request or technical assistance request, and we'll respond to you within 1 to 3 business days. And this slide shows how quickly and easy that is to do. And our producers will drop the link in the chat as well, so you have access to that. And we'll send that in the handout notes as well. Lastly, before we log off, if you could please take a few moments to scan this QR code. The link will also be in the chat to complete our survey and provide feedback on the learning community. We are SAMHSA funded, and the feedback does help with continuing the work that we do. So if you could just take the time to fill out that survey, it really does help us, and it really supports the work that we are all doing in our communities. Awesome. Well, thank you all so much for being here today. We are going to continue this conversation in our next learning community. Like we said earlier, this is just a continuation of what we started today. We'll dive a little bit deeper into those strategies, and motivational interviewing will be one of the examples we'll talk about, in addition to some other strategies as well. If your organization would like to reach out for, again, technical assistance or consultations, you can send us an email there. We encourage you to visit our website and look at our additional resources there. We have learning modules. We also host these learning communities regularly as well, and the topics vary, and we are always open to topic suggestions. I would like to just close today's session by taking a moment to thank all of you participants for being so active in our conversations. We really appreciate your insights, and this collaboration is really important for serving the communities that we do serve. Thank you to our subject matter experts for their insight, and our facilitators, Dr. Mutamajero and Dr. Zia Ali, for sharing your expertise. Thank you to the RMTAC team, especially our producers, for all your hard work in making this a success. I hope you all have a wonderful rest of your afternoon. I know we're like a little behind on time, so thank you for bearing with us and being here. Please feel free to stay and ask any questions by unmuting yourself or dropping them in the chat. We'll be here for a couple more minutes, just hanging out. Happy to answer any questions. But again, I really thank you all for your time and your dedication to your communities.